help of this structure which is called as bougie. This is called as bougie. Okay, what we'll do is basically we'll follow the anatomy. If at all you are seeing just the epiglottis, the bougie, this end of the bougie will be curved like this. Okay, so what you will do is blindly you insert the bougie, following the epiglottis you will enter the trachea. You will feel the tracheal rings while you enter it, and then you just slide over the tube. This is bougie and this is stylet, guys. This thing is called as stylet. Okay, stylet is basically used for when you're using flexometallic tubes, and all will come to it what flexometallic tubes are. Okay, so that's regarding Cormack-Lehane grading and endotracheal tube. Now guys, remember, once you intubate the patient, at what position are you fixing the endotracheal tube? Now I'm not asking you the length at what you're fixing. Basically I'm asking, in the, this is the trachea and these are the lungs. Okay, these are the lungs. Now, where will you fix the endotracheal tube inside the trachea? When you're fixing the endotracheal tube, it should be always 3 to 4 centimeters above the carina. 3 to 4 centimeters above the carina. Okay? If you advance it too deep inside, either it can go into the either of the bronchus. Okay? So, endotracheal tube should be fixed 3 to 4 centimeters above the carina, so that you can ventilate the patient's both lungs. But how will you confirm, guys? Once you are in the trachea, how will you confirm that your tube is in the trachea or not? You can auscultate. There are some screening things you can auscultate. You will see some fog coming on the endotracheal tube. Why? Because the patient is breathing, those airs will come as a fog or fumes. But remember, these are not confirmatory. Confirmatory test is what? Once you put the endotracheal tube, connect to the capnograph, and on the capnograph you will see a waveform. So remember, guys, the best confirmatory test for endotracheal intubation, for endotracheal intubation, is always capnograph. It is the surest test to confirm endotracheal intubation. Now, in this capnograph, what you will see, this is the normal capnograph reading. Okay, the normal reading is usually 35 to 45 mm of Hg. Now, when we are discussing about capnograph, we need to discuss the phases of capnograph. The first phase of capnograph, as the patient is exhaling the carbon dioxide. Okay, remember, capnograph is nothing but EtCO2. EtCO2. The first phase is called as inspiratory baseline. Very, very important. Inspiratory baseline. The second phase of capnograph, which you see over here, now is the patient exhaling. So it is called as expiratory upstroke. Whereas the third phase of capnograph is called as, very important, alveolar plateau. And the last phase of capnograph is called as inspiratory downstroke. Inspiratory downstroke. Phase 0 is inspiratory downstroke. Now guys, remember, between phase 2 and phase 3 there is an angle called as alpha, and phase 3 and phase 0 there is an angle called as beta, and this angle is very important, my friends. Why? Because at this point only you will measure the normal capnograph reading. Okay, at this point capnograph is measured, or this point the readings is measured. So this is the normal capnograph. Now imagine, guys, you have intubated the patient. After intubation you will see normally this capnograph, but instead of this capnograph, after intubation you are seeing a capnograph which is looking like this. This means like this. What does it mean? Yani you are seeing a flat line of capnograph. There is no rise of EtCO2. That means, are you in the trachea? No, sir. You might be in the esophagus. You will see a flat line capnography. Sometimes you are in the trachea, but still you are seeing a flat line capnography. What? Why? What could be the reason for it? You are in the trachea, but you are seeing. Imagine you have intubated, you are in the trachea, and now the patient develops cardiac arrest. If the patient develops cardiac arrest post intubation, you will see a flat line capnography. Apart from that, flat line capnography can also be seen if circuit is disconnected. If the breathing circuit is disconnected, you will see a flat line capnography. Apart from that, in complete bronchospasm cases also you will see a flatline capnography. This is capnograph value of 0 or flatline. Now, next guys, imagine you have intubated, okay, and initially you were seeing a normal capnograph, but slowly what you see is on the capnograph, it is coming like this. ठीक है, like this. Normal capnograph should look like what? It should look like this. ठीक है, but it is looking like this. It looks like a fin of the shark. Shark fin capnography is seen in what case, guys? In case of bronchospasm. In case of bronchospasm, you will see a shark fin capnography where the ATCO2 initially it will be low. Initially the ATCO2 will be low, but as the bronchospasm worsens, the ETCO2 also rises. ETCO2 यानी कि capnograph value also rises. That is Shackford capnography, which is seen in that conditions. Okay. Next, guys, step ladder capnography. Step ladder capnography means what? You have intubated the patient, okay, and after intubation, what do you see is capnograph reading slowly increasing like this in a step ladder manner. Step ladder increase of the capnography could be seen in what condition? If the patient is having malignant hyperthermia, yani कि patient has landed up into malignant hyperthermia. Imagine you are using scoline or you are using some inhalational agent such as halothane, which has triggered his rhinodine, abnormal rhinodine receptors to cause malignant hyperthermia. In malignant hyperthermia, you will see a capnograph value like this, and usually the capnograph value is 100. That is step ladder capnography seen in malignant hyperthermia. Next, capnograph sometimes after intubation, after half an hour of intubation. Capnograph was normal, but slowly what you are seeing is it is now coming like this. Is it coming from the baseline? No. If it is not coming from the baseline, it is rising above the baseline. What does it mean? Patient is re-inhaling his own carbon dioxide. Now, when does patient re-inhales his own carbon dioxide, guys? When the expiratory valve of the circuit is faulty. In cases of faulty expiratory valve or faulty expiratory valve, or guys, remember in closed circuit, who's the thing that is absorbing carbon dioxide, guys? In closed circuit, it is basically the soda lime. So in case of soda lime exhaustion also, you will see capnograph value like this. Okay, so capnograph value above the baseline you will see in these conditions. Okay, next, guys, sudden fall in EtCO2. Okay, means normally the capnograph value was coming like this, but suddenly you will see capnograph value going down. When will it happen, guys? Normally, imagine a patient is posted for surgery like lap hysteroscopy. If the patient is posted for hysteroscopy, the surgeon will be just giving fluid to the patient. As he is giving fluid to the patient, and remember, guys, during hysteroscopy, when the fluid is given, all the fluid has to be measured. How much is going in and how much is coming out. But if at all the surgeon is inadvertently using the fluid and all, what will happen? That fluid, while he's pushing inside the uterus, it has to go somewhere. If there is excess amount, where will it go? It can go into the blood vessels, and patient might develop venous air embolism. And the patient develops venous air embolism during surgery. What will you see in the capnograph? You will see a capnograph value which is always decreasing. Sudden fall of the EtCO2 is seen in patients who are having venous air embolism. Okay, capnograph usually looks like this in case of VAE. Now, guys, regarding venous air embolism, what are the features of venous air embolism? How is the airway pressures in venous air embolism? Remember, EtCO2 falls, but how about the airway pressures? Airway pressure increases, sudden increase in the airway pressure, and you might also see a murmur which is called as Millville murmur. Millville murmur. Okay, in those cases, what you need to do, you need to stop the surgery and you have to notify the surgeon that please you don't use that fluid. I think the patient had land up into venous air embolism, and again the management will be different. We are not discussing about the management, just we are discussing about what the capnograph value, which usually is seen in venous air embolism. But remember guys, for venous air embolism, the best thing to diagnose venous air embolism is usually the transesophageal echocardiography. Okay guys, so anyways, that's regarding what, that's regarding the sudden fall in EtCO2. Next, curar notch capnography. Now curar notch capnography, imagine guys, you are doing a surgery, the patient is having a normal capnograph, but all of a sudden your patient develops capnograph value like this. You can see over here what is happening to the capnograph. Is it normal? No. You can see a notch developing over here. Notch developing, what does it mean guys? When you see a notch developing, that means the patient is spontaneous breathing. So curar notch means what guys? It means return of spontaneous breathing. In case of spontaneous breathing, you will see curar notch. So what is the next step guys? In this condition, the next step would be what? The patient is in still general anesthesia, and if he's spontaneously breathing, can the surgeon continue the surgery? No. So next step is what? You give the top up dose of muscle relaxant. Top up dose of muscle relaxant is given. So that's regarding the curar notch capnography. Next, hyperventilation. In case of hyperventilation, how is the capnograph? When you hyperventilate the patient, the capnograph will be like this. Hyperventilate means you are increasing the respiratory rate, and when you are increasing the respiratory rate, carbon dioxide is usually washed off. Okay? So in case of hyperventilation, the capnograph usually is like this, yani कि it is below the baseline. In case of hypoventilation, yani कि you are decreasing the respiratory rate, how will be the capnograph? Usually the EtCO2 will rise only. Why? Because you are hypoventilating, so EtCO2 will be like this. Okay, in case of hypoventilation. So that's regarding what guys? That's regarding the capnographs. Now coming to this story or question. Okay, you are about to anesthetize a patient for a major spine surgery under general anesthesia, which is done in prone position. Once the patient is turned to prone, access of the airway becomes extremely limited. Which kind of endotracheal tube you will choose and why? Now, will you choose a normal PVC tube for prone position? Never, guys. If you use a normal endotracheal tube and keep the patient prone, then what will happen to your endotracheal tube? You can see in this picture, your endotracheal tube can bend and it can kink. Kinking can happen. So what you will do? Which kind of endotracheal tube will you put in this patient? You will go for this tube, which is called as flexometallic tube. Flexometallic tube. And while putting the flexometallic tube inside the trachea, you usually take the help of a stillet. You first put a stillet into the tube and then put it. Okay, so that is flexometallic tube, usually used for prone position surgeries. So we are discussing about other types of endotracheal tubes. In that, flexometallic tube is used, which is used for prone position surgeries. Okay, imagine if the patient is having oral cavity cancers. For oral cavity cancers, what we need to use guys? Oral cavity cancers, you have to use RAE tube, which is called as ring Adair Elvin tube, commonly used for oral cavity cancers. Okay, these are basically the nasotracheal tubes. Okay, next is what guys? This a long tube. This long tube is called as double lumen tube. This double lumen tube is used for what procedure? Double lumen tube is used for, usually, remember guys, if at all a patient is having carcinoma of lung, okay, cancer of lung, will you put a normal endotracheal tube to ventilate his lungs? No. Remember, for carcinoma of cancer of lung, the surgeon will be telling that I'll be removing this tumor, and he'll be asking to the anesthetist which anesthesia you will give. As an anesthetist, I'll tell what? I'll give the patient general anesthesia. But guys, remember, if you are giving general anesthesia to the patient, then how will you put the endotracheal tube? The surgeon will be telling you that please do not ventilate the lung which is having cancer, just ventilate the other lung. So how will you ventilate only one lung, leaving the other lung? With the help of double lumen tube. Why? Because double lumen tube will go into the, we are basically pushing the double lumen tube into the lung which is normal. Okay, so double lumen tube is usually used for one lung ventilation surgeries requiring one lung ventilation, such as basically patient posted for any carcinoma, cancer of lung, or any lung abscess surgery. Also you can use double lumen tube. Lung abscess, you can use double lumen tube. But how will you confirm the position of double lumen tube? Now don't tell me capnograph, sir. Capnograph will not tell you. Okay, once your double lumen tube is into one of the bronchial lumen, you have to confirm it. For confirmation can be done by fiber optic bronchoscope. Fiber optic bronchoscope. Okay, now I'll just show you guys how the fiber optic bronchoscope looks like. Okay, in this picture you can see I am holding a fiber optic scope. This is the fiber optic scope, guys. Okay, fiber optic scope. On the tip of the scope you will see a camera which can confirm. You are putting this scope into the mouth and you're checking the patient. You're checking the position of the tube, double lumen tube. Okay, that's regarding the fiber optic. Next, what is this tube, guys? What is this tube on your screen? This tube on your screen is called as esophageal combi tube. Esophageal combi tube. Now imagine, guys, you are in a casualty and you have a patient who is in a semi-conscious or a drowsy state or having a GCS of less than 7. GCS of less than 7 means it is an indication for you need to go for intubation, but you don't know how to intubate the patient. How will you intubate in that scenario? If this tube is there, don't worry. Why? Because this tube, you are putting the tube blindly into the patient's mouth. Two things can happen. Either it goes into the esophagus or into the trachea. If it is going into the esophagus also, you're not worrying. Why? Because you will be blocking or you will be inflating this cuff and you will be ventilating through this ports, which will ventilate the trachea only. Okay, so esophageal combi tube is commonly used for emergency scenarios. Now, starting with this topic, we'll discuss about this airway devices, guys. This airway devices are also called as airway adjuvants. In this airway adjuvants, what we need to remember is, if at all the patient is there who is, imagine a patient is there who is coming with a eclamptic fit, okay, and you need to secure the patient airway. At the same time, the patient is having clenching of the teeth. She is not allowing you to put the airway, and you're not giving any anesthesia, but still you need to protect the airway. In that case, you need to go for two airway adjuvants, guys. What are the two airway adjuvants which are available with us? One is called as the nasopharyngeal airway, other is called as oropharyngeal airway, or it is also called as Goodell's airway. Okay, now when the patient is having a clenched teeth and she's not allowing you to put a airway through the mouth, you can put the airway through the nose, and that is nasopharyngeal airway. When you are putting a nasopharyngeal airway, guys, remember you need to take that size of that airway. How will you know the size of the airway? Take the airway and keep between the tip of the nose and the tragus of the ear. If it is fitting, then you have to take that and you have to put that airway. Now just look over here, guys. In this video, I'll be showing you how am I putting a nasopharyngeal airway into the patient's nose. I pre-lubricate the airway with lignocaine gel, and then I will introduce the airway, and once the airway is introduced, I'll take an ambu and I'll just ventilate the patient. Okay, so this is regarding what? Nasopharyngeal airway. But remember, guys, nasopharyngeal airway, I told you the exact size of nasopharyngeal airway, how to determine it. But you also have to remember there are some contraindications. What contraindication? In case the patient is having some bleeding disorder, don't go for it. Or if the patient is having skull base fracture, don't go for this airway. Why? Because this can easily pierce it and it can damage the brain also. So in those cases, you don't go for it. Okay, next, Goodell's airway. Goodell's airway is usually used in unconscious patient, not conscious patient. Conscious eclamptic patient, no, unconscious patient. Patient not breathing and unconscious. Why? Because Goodell's is you are putting through the mouth, and if the patient is conscious and you put this airway, the patient will have gag reflex. So remember, Goodell's airway is usually used for unconscious conscious patient. And how will you determine the Goodell's airway size? You keep the airway between the tragus of the ear. So remember, NPA is determined by keeping the airway between the tip of the nose and tragus of ear, whereas Goodell's airway is determined by keeping the airway between the tragus of ear and angle of mouth. ठीक है, between the tragus of ear and angle of mouth, if it is fitting, then you can use that size Goodell's airway. Now guys, next, a patient rushed into the casualty with severe breathlessness. His saturation was 88% on room air. The nurse asked the doctor, should we start oxygen? Yes, the doctor replied, yes. Please start with the low flow oxygen device, which is nasal cannula. So he gave nasal cannula, saturation improved to 89%, but not enough. Then the nurse asked, what next, sir? Saturation is not improving. So he told, please go for the face mask. Face mask, yani he is escalating from the nasal cannula, face mask. After face mask also, nurse is telling, still the patient saturation is not improving, sir. What next? So now he is telling, put a NRBM. What is NRBM? Non-breathing mask, which is commonly used in COVID time with a rebreathing bag and all, okay? So NRBM. And the doctor is telling, put it at 15 liters per minute. And after some time she's telling, doctor, with NRBM also it's not improving. Doctor will tell, put a Venturi mask. But after Venturi mask also it's not improving. Then the doctor will tell, put a high flow nasal cannula. High flow nasal cannula, and now the saturation becomes 96%. So now cut short the story, we are going into the oxygen delivery devices. The patient came with a low saturation. We started with the low oxygen delivery device, low flow oxygen delivery device, which is called as nasal cannula. So basically guys, remember, oxygen delivery devices are divided into two categories. One is called as low and one is called as high flow. Low flow means you are having nasal cannula. Then if nasal cannula doesn't improve, then what guys? It is simple face mask, and then NRBM. NRBM is what? Non-rebreathing mask. Okay? So anyways, this was the first device which was used for the patient. It did not improve. Then second device is face mask. Then NRBM. Then Venturi. And last is high flow nasal cannula. The questions that are being asked is what is the flow and what is the flow rate and what is the FiO2 delivered. So remember guys, nasal cannula, starting in the case we started nasal cannula, and nasal cannula will deliver oxygen at 1 to 6 liters, which will deliver in turn an FiO2 of 25 to 45%. If it is not improving, you go for face mask, which will deliver an oxygen of 6 to 10 liters. That's why the doctor told to go for face mask. More oxygen is being delivered. Na? So FiO2, it will deliver in return of 35 to 65%. Then patient saturation was still not improving. Now NRBM. NRBM will, we can keep a flow rate of 10 to 15 liters, which will in turn deliver an FiO2 of 95%. If still not improving, Venturi mask. With Venturi mask, 2 to 15 liters of oxygen can be given, which will deliver oxygen of 24 to 60%. It is basically a fixed oxygen delivery device. As well as, remember always one thing guys, Venturi mask works on Bernoulli's principle, air flowing through the narrowed passage. Okay, Bernoulli's principle. If still Venturi mask doesn't improve, then what you need to go, high flow nasal cannula, by which you can give 40 to 60 liters of oxygen, which will deliver 100% of FiO2. Okay, that's regarding what guys? That's regarding these oxygen delivery devices. Now guys, regarding Venturi mask, I told you Venturi mask works on Bernoulli's principle. There have been some questions asking you about the colors of Venturi mask. If you go into the picture, you will see different colors of Venturi mask. Okay. Now, there have been questions on the Venturi mask also. There is a mnemonic to remember the Venturi mask, guys. What is the mnemonic? Boy was often yelling, run girl. Okay. B stands for, boy stands for blue in color. W stands for white. O is orange. Yelling, yellow. Run, red. and G is green in color. I told you venturi mask will deliver 2 to 15 liters of oxygen. So if you remember the mnemonic in this manner, you have to remember boy and a K, it is starting, I told you 2 to 15 liters of oxygen can be delivered. So blue will deliver 2 liters, white will deliver 4 liters, orange 6 liters, yellow 8, red 10 and green 15 liters. Now it will deliver how much FiO2, that also we have to remember. Remember guys, with blue we can deliver 24% of FiO2, with white we can deliver 28% of FiO2, with orange we can deliver 31% of FiO2, with yellow 35%, with red 40% and with green it is 60%. That's why I told you 24 to 60% of FiO2 can be delivered through the venturi mask. Okay, that's regarding the venturi mask. Now we are still into that case. If at all our patient saturation is not improving with the help of high flow nasal cannula, then in that case you have to go for ventilator. Ventilator means what? Invasive or non-invasive? First you go for a non-invasive, then you go for a invasive ventilator. If the patient health condition is not improving, then only. So remember guys, we go for ventilation if the patient saturation is not improving. Why? Because remember, below saturation of 90%, tissues become vulnerable to hypoxia. Okay, so in ventilators we are having two types. One ventilator is called as non-invasive, other is invasive. First we'll discuss the non-invasive ventilator. Non-invasive means it is not put through the ventilation, is not given through the tube and all. Non-invasive means through the mask you are ventilating the patient. But the vital prerequisite for non-invasive ventilator is what? Patient should be conscious and patient should be empty stomach. Why sir? Why? Because remember, if he is unconscious or he is full stomach, when you are pushing the air through the non-invasive ventilator, you are pushing much high pressure air. So what will happen if he's full stomach? He will aspirate, and if he is unconscious he will definitely aspirate. So that this is the vital prerequisite for non-invasive. What are the two modes of non-invasive guys? There is CPAP and there is BiPAP, continuous positive airway pressure, and there is bi-level positive airway pressure. Okay? CPAP is usually used for mild to moderate COPD patients, whereas BiPAP is used for severe COPD patient. In BiPAP there are again two modes, the inspiratory pressure mode and the expiratory. We usually use a high inspiratory and a low expiratory pressure for BiPAP. So this is regarding the non-invasive ventilator. Now coming to the invasive ventilator. Guys, remember, if non-invasive is not working or the patient is like becoming unconscious, if you suspect that the patient cannot sustain his airway, if his GCS is below 7 or below 8, you go for intubation. Once you intubate the patient, you go for invasive ventilator. In the invasive ventilator, there are modes. The first mode is called as CMV. Guys, remember, in the ventilator, when you are going for invasive ventilator, you have to remember two things. Two things are of very much importance. One is called as a tidal volume. Other is called as a pressure. Yani basically the volume and the pressure. Okay, now remember, the first mode of invasive ventilator is called as a CMV. CMV mode means what? Continuous mandatory ventilation. That is the initial mode. If the patient is brought in a severely unconscious state, he is not at all breathing and all, and you know that the patient is not breathing, I want my ventilator to fully support the patient for his ventilation, then you have to use CMV. Why? Because CMV mode is the only mode of ventilator that is controlling both the components. What components of the patient? First component is the volume, otherwise is the pressure. So both the components are covered, or both the components are helped by this mode. So CMV mode, what is the control variable by the ventilator? Control variable is always in CMV, it is volume as well as the pressure. Both are controlled by the patient, both are controlled by the ventilator. Ventilator will basically tell you that, doctor, please, I don't want your patient to move, I will do all the job by myself, you just tell your patient to be relaxed. And as a doctor, what should I do now? If I am keeping the patient on CMV mode, I will now have to make the patient relax, so I will heavily sedate the patient. So if we go for the sedation, if we look at the sedation, how is the sedation given in CMV mode? The patient is heavily sedated. Now guys, remember, this mode sometimes can be good, sometimes can be bad for the patient. How can it be bad for the patient? When we keep the patient on this mode for a longer period of time, the patient becomes totally dependent on this mode. Now he is not at all breathing by his own. Why? Now his muscles have forgot to breathe only. Due to that, this patient might develop what side effect due to this mode, guys? Atrophy of muscles. So that is regarding what mode? CMV mode, the first mode. If at all the patient is improving on the CMV mode, we don't keep the CMV mode for a longer period of time. Why? Because atrophy of the muscles could happen. So we are now, if the patient is improving on the CMV mode, slowly we go into the step down mode. So guys, what is the next mode of ventilator after CMV? If the patient is improving, you go for ACMV mode. In the ACMV mode, there are two modes. One is called as volume control mode, one is called as pressure control mode. When do you say volume control? When you are setting a volume. When the control variable is what, guys? The control variable is volume. You are setting a tidal volume and a ventilator is generating a pressure. That is called as a volume control mode. Yani कि you are keeping a tidal volume. Okay, I'll keep 500 ml, 600 ml. That is a volume control mode. How is the sedation required over here? Moderate sedation is required in volume control mode. Next is pressure control mode. Pressure control mode is commonly used in ARDS patient where the compliance of the patient is low, so we used pressure control mode. Now look over here. In pressure control mode, what is the control variable? Yani which control variable means what you are controlling. It is basically the pressure. In pressure control mode, the control variable is the pressure. And how is the sedation required over here? In pressure control also, moderate sedation is required. Now what are the side effect of these two modes, guys? Sometimes depending upon it depends. The side effect depends from patient to patient. Depending upon the patient, sometimes the patient might be hyperventilated. Usually the patient is hyperventilated in the cases of volume control mode, and due to hyperventilation, patient might have alkalosis. Patient might have respiratory alkalosis. Okay? But usually for pressure control mode, the side effect that you see is what? The patient is hypoventilated and the patient is having respiratory acidosis. Now guys, it doesn't mean that in volume control you don't see respiratory acidosis. It can be alkalosis as well as acidosis. But usually with volume control, you will see the patient will be hyperventilated and patient will be having alkalosis, respiratory alkalosis. Next, if the patient is still improving on this mode, then we can go for the other step down mode, which is called as spontaneous mode. In the spontaneous mode, we are having what modes, guys? We are having the SIMV mode and the pressure support mode. Okay? SIMV and the pressure support mode. Now in the SIMV or the pressure support mode, just look over here, guys. Imagine this is the patient breath. Patient is taking this breath, but that breath is not enough to maintain the tidal volume. Then what will happen after 2 or 3 breaths? The ventilator will give a one breath. Okay? Then again it will allow the patient to breathe. Okay? But due to this, the side effect what could come over here is what? Asynchrony of the breathing pattern. Okay? Asynchrony of the breathing pattern can happen. And due to this asynchrony, the respiratory rate might decrease and the patient might have again acidosis. Patient might have again acidosis. Okay. So remember, this is regarding what modes? SIMV mode. But remember, if the patient is still improving on the ventilator and on the SIMV mode, all patients who are on SIMV mode won't develop acidosis unless and until the patient's underlying condition is not improving and you have kept the patient on SIMV mode, you will see respiratory acidosis. So this is regarding what, guys? This is regarding the ventilator. Okay. Now, once you are setting the ventilator, you have to set some readings on it. Okay. You have to set the respiratory rate, the tidal volume, the FiO2, PEEP and I/E ratio. The normal respiratory rate that we keep on a ventilator, it is 12 to 18 per minute. Okay. Tidal volume is 6 to 8 ml per kg of the patient. FiO2 is 21 to 100%. PEEP is usually 5 to 24, and inspiratory expiratory ratio is usually 1 is to 2 or 1 is to 3. Now imagine guys, the patient is having respiratory acidosis. Okay, if the patient is having respiratory acidosis, in that case, what reading will you change in the ventilator so that this respiratory acidosis is easily managed? I will always tell that respiratory acidosis can be managed by with this respiratory rate. I will increase the respiratory rate in case of respiratory acidosis. I will increase the respiratory rate, okay, to 20 or up to 24 also, which will manage respiratory acidosis, okay. If the patient is having ARDS, what you will do to the tidal volume? In case of ARDS, already the lungs are like in a very bad state and all. You don't have to overinflate them by giving a high volume, a high tidal volume. So that was regarding respiratory rate. Now starting with tidal volume. Guys, remember, if at all the patient is having ARDS, if the patient is having ARDS, will you overinflate his lung by giving a high tidal volume? Never, sir. If you overinflate, if you give a high tidal volume, the lungs are already in a bad state and the lungs might collapse also. So you give a low tidal volume, yani 4 to 6 ml per kg body weight in case of ARDS. Okay? FiO2 you are keeping 21 to 100%. Next, you are adding PEEP to ventilation. Why do you add PEEP? PEEP is nothing but positive and expiratory pressure. You add it to the ventilator. Why? Because PEEP improves oxygenation. Very, very important. Regarding PEEP, we are keeping a PEEP of 25 to 24, right? Why you are adding PEEP, guys? PEEP improves oxygenation of the patient. It improves oxygenation. Okay. Now, inspiratory expiratory ratio, how much you are keeping? 1 is to 2 or 1 is to 3. But if the patient is having ARDS, which is refractory, and the patient is not responding to the normal ventilator setting, then in that case, you can go for reverse ratio ventilation. Reverse ratio ventilation is what? You are reversing the ratio 3 is to 1 or 4 is to 1. Okay? 4 inspiratory is to 1 expiratory or 3 inspiratory to 1 expiratory. You are reversing this ratio. In ARDS, you can also go for prone ventilation, that is different. Okay? Prone ventilation. So these are the settings, and these settings can be altered according to the need and according to the condition of the patient. Okay, that's regarding what? That's regarding the ventilatory settings. Now guys, I told you PEEP. PEEP is nothing but positive and expiratory pressure, which usually helps to improve oxygenation. Apart from oxygenation, guys, it prevents atelectasis. Very, very important. Atelectasis. And decreases the work of breathing. Now, PEEP is usually used for what patients? ARDS patient and pulmonary edema. But there is some side effect of PEEP. What is the side effect of PEEP? If you give too much of high PEEP to the patient, it will decrease the venous return, which can cause decrease in the cardiac output and hypotension. Okay. For this reason, when a patient is in shock, you don't give PEEP. Okay. Next, PEEP is also contraindicated in increased intracranial pressure patient. It will increase the ICP. Okay. So this is regarding the positive and expiratory pressure. So whenever the patient is having a like head injury or something, you never add PEEP. Okay. Next, ACLS or BLS. Guys, what is meant by ACLS or BLS? ACLS is nothing but advanced cardiac life support. BLS is nothing but basic life support. Now guys, over here in this picture, patient is lying in which position? This is called as a rescue position or lateral position. Rescue position or lateral position. When do you keep the patient in this position? Okay, when he's having, remember, imagine a patient is collapsing in front of you. Okay, he just fall down in front of you. But when you go to the patient, he's having pulse, he's having breathing. Yani ke, now you don't have to give him CPR, you don't have to give him breaths and all. Okay, you just have to protect his airway by keeping the patient in a lateral position, so that if there is some secretions in his mouth, it will just go, it will just come out, it won't go inside the trachea and choke the patient. So if the patient is having pulse and breathing present but he is not conscious, he is unconscious, you go for this position which is called as rescue positions. Okay. Now if the patient has collapsed, then what you need to do? If the patient has collapsed, you will do what? Yani you are going on a road, you see a person suddenly collapsing, the first step what you do is what? That's very important. The steps of BLS, you have to remember SCCS. S stands for what, guys? S stands for, first you look for the scene safety. Scene safety, the patient has collapsed on the road, take the patient to the corner, make the scene safe. Okay. Next is what? Check for the response. Check for response. Tap on the patient's shoulder and check for the response. If he's not responding, the third C stands for what? Call for help. Call for help, so that your friend who you call for help, he can get an ambulance or he can get any AED device. Okay. C stands for what, guys? Once he call for help, what you are doing with the patient, you have to check for the pulse as well as breathing. Which pulse you will look for? Always carotid pulse, unless and until it's an infant. In infant, brachial pulse. Okay. Last, if there is no pulse, no breathing, then that is no pulse and no breathing. That is a sign that you need to start CPR. Very, very important. Now, guys, while initiating your CPR, are you going with ABC protocol or CAB protocol? ABC is nothing but airway breathing circulation. CAB is nothing but circulation airway breathing. Always remember, guys, we are going with what? The CAB protocol. Circulation yani ki compression. First you start with compression, then you secure the airway, or after 30 compressions you give breath, and then you are giving the rescue breath to the patient. Okay? Now, guys, imagine the patient is having no pulse, no breathing, you have start your compressions. How are you starting? How many compressions you have to give in a minute? In a minute, always you have to remember 100 to 120 compressions per minute you have to give. And remember, are you giving this continuous? No, sir. I will stop for 30. I will give 30 compressions, stop, and then give 2 rescue breaths. 30 compressions, stop, give 2 rescue breaths. यानी कि 4 sets of 30:2 I will give in 1 minute. What is the depth I need to maintain, guys, in adults? Remember, it is 2 to 2.4 inches or 5 to 6 centimeters depth, not more than that, not less than that. Why? Because if it is less than that, it's waste. If it is more than that, you will harm the patient. Okay, so that is the depth of the chest compression. Okay, next, guys, what is the ratio that we need to remember? Ratio is 30:2 in 1 minute, 100 to 120. But how many sets of 30:2? 4 sets of 30:2 in 1 minute you have to give by hook or crook. 100 to 120 compressions you have to finish in a minute. But remember, guys, you have to allow a complete chest recoil while giving chest compressions. It doesn't mean that you're giving just too fast. When you are giving too fast, chest recoil won't happen. That's why 100 to 120 compressions if you are giving, then chest will be completely recoiling. In case of infants, what is the depth of chest compressions? In infants, it is always 1.5 inches or 4 centimeters. In case of children who are more than 1 year, in 1 year child, you have to go for 2 inches or 5 centimeters or 1/3 of the anterior posterior diameter of the chest. What is the compression to ventilation ratio in case of adults and pediatrics? So remember, guys, in adults, the compression to ventilation ratio, in if at all there is a single rescuer, there is always 30:2. In case of pediatrics, also 30:2. If there are more than one rescuer in adults, again 30:2. In pediatrics, 15:2. Why? Because they are having a high respiratory rate, requires 15:2. Okay. Once you place an advanced airway, you are giving CPR and now you have placed an endotracheal tube or an LMA. In that case, will you pause after 30 compressions? No, sir. You will be continuously giving 100 to 120 compressions in a minute. But how are you giving rescue breaths? Every 6 seconds you are giving a rescue breath. Okay. In case of adults, every 6 seconds you gave a rescue breath. In case of pediatric, every 2 to 3 seconds you are giving one rescue breath. Okay. What is the compression to ventilation ratio in a newborn? It is 3:1. 3 compression to 1 rescue breath. Okay. Now, this is the ACLS algorithm. Very, very important, guys. Whenever the patient is in a cardiac arrest state, you start with the ACLS algorithm. You start the CPR, give oxygen, connect to the defibrillator and all. And then you determine whether it is a shockable or a non-shockable rhythm. If it is a shockable rhythm, you deliver shock. What shock, guys? Asynchronous shock you give to the patient. Remember, guys, after 2 minutes you are checking the rhythm, and if required you are giving the shock. Regarding the shock, remember, after 2 shocks you are starting adrenaline, and after 3 shocks you are starting amiodarone. That is very important in shockable rhythms. Okay, whether in case of non-shockable rhythm, it is showing asystole, you don't have to give shock, you just have to continue the compressions and you start adrenaline as soon as possible. But remember, guys, after 3 shocks and all, you start amiodarone and rule out. Remember, in shockable rhythm, after 3 shocks you are ruling out 5 H's and 5 T's after 3 shocks. Whereas in the case of non-shockable rhythm, if the patient is on flatline, you are continuing compressions, you are starting adrenaline as soon as possible. And remember, once you start adrenaline, every 3 to 5 minutes you have to repeat it, and you have to rule out 5 H's and 5 T's as soon as possible in case of non-shockable rhythm. So anyways, guys, we are discussing about what? We are discussing about the ACLS algorithm. In the ACLS algorithm, I told you we are using defibrillator. Remember, if the patient is having a shockable rhythm. So in shockable rhythm, we are using monophasic asynchronous cardioversion. Asynchronous monophasic means how much shock can be delivered? 360 joules. Whereas biphasic means 120 to 200 joules of shock can be delivered. And shock is only delivered only when the patient is having a shockable rhythm. What two shockable rhythms? Ventricular tachycardia or ventricular fibrillation. Fibrillation is basically a scribbling type of rhythm on the ECG, is called as fibrillation. Okay. Now, I told you, if the patient is having shockable rhythm, after 2 shocks, what are you giving? You are giving adrenaline. Very, very, very important. Adrenaline. When you are giving adrenaline or epinephrine, what is the dose of it? The dose is 1 milligram. What is the dilution of adrenaline that is given in cardiac arrest? It is very, very simple, guys. 1 is to 10,000. How it is given, guys? IV route. If IV is not possible, then what? Then you give intraosseous. If intraosseous in the bone. If that is also not possible, if you have secured the airway, pour the adrenaline into the endotracheal tube. Okay, so remember, what is the dilution of adrenaline in cardiac arrest? 1 is to 10,000. In the case of local anesthetic, the dilution is 1 is to 2 lakh. 1 is to 2 lakh adrenaline dilution. Okay, dilution of adrenaline in case of anaphylaxis, it is 1 is to 1000. Okay, routes I have already told you. IV, if IV is not possible. IO, if IO is also not possible, then endotracheal route. Okay, that's regarding what, guys? Adrenaline. Now, if at all the patient is having a non-shockable rhythm, I told you what you need to do. You need to start CPR, give adrenaline as soon as possible, and rule out 5 H's and 5 T's. Remember, in whether in case of shockable or non-shockable, you have to rule out. In case of shockable, you are ruling out after 3 shocks. In case of non-shockable, you are ruling out 5 H's and 5 T's like immediately or basically after starting adrenaline. Okay, what are the 5 H's? These are the reversible causes. Remember, 5 H's are nothing but hypoxia, okay, hypovolemia, hypothermia, hydrogen ion acidosis, hypo or hyperkalemia. These has to be ruled out. Okay, and 5 T's are what, guys? 2 T's related to the heart. What 2 T's related to the heart? It is cardiac tamponade and it is coronary thrombosis. Coronary thrombosis. 2 T's related to the lung. It is pulmonary thrombosis. So here is coronary, here is pulmonary thrombosis, and T is what? Tension pneumothorax. Tension pneumothorax. This all has to be ruled out. Last T is what, guys? Last T is toxins. Sometimes the patient might have taken some drugs. Drug overdose can also cause cardiac arrest. So these are the reversible causes of cardiac arrest which has to be ruled out. Okay. Now, remember, in cardiac arrest, the chain of survival is what? Previously, we were having the chain of survival recognition, immediate CPR, rapid defibrillation, basic and advanced emergency medical service, and advanced post-arrest care. Now in the chain of survival, the next thing that is added is recovery. Very important, guys. The sixth chain of survival is what? It is recovery, right? Now, if at all, guys, remember, after doing CPR and all, you have seen after doing CPR, now you are seeing a pulse, yani कि you have achieved a return of spontaneous circulation, that is called as ROS. Then what should be your aim? Once you have achieved the ROS, now you have to manage the patient's airway. You have to look whether the patient is alert, conscious, unconscious, if he is able to manage his airway by himself, or if he requires airway management. If he requires airway management, intubate the patient and all. Okay. Then you have to maintain the respiratory parameters. Yani कि basically you have to maintain the SpO2 between 92 to 98% or up to 100% also. That is the aim. Okay. Next, you have to maintain the BP of the patient. BP of the patient means systolic BP should be more than 90, or the MAP value should be more than or equal to 65 mm of Hg. Okay, we are talking about post cardiac arrest care, when the patient has returned his, when there is return of spontaneous circulation in the patient. Now, guys, remember, in this phase, the most important thing is targeted temperature monitoring, where we keep the patient's temperature between 32 to 36 degrees Celsius, which will decrease the basal metabolic rate of the patient. That is very, very important. In what, guys? In post cardiac arrest care. Okay. Now, guys, we'll discuss something about tachycardia. Guys, remember, if the patient is having a tachycardia, okay, and now in tachycardia also we are having two tachycardias. One is called a stable tachycardia and unstable tachycardia. Okay, I'm not going into the details of what are the types of tachycardia and all, but you have to remember, if at all the patient is having an unstable tachycardia, first we need to understand what is unstable tachycardia. Unstable tachycardia means patient having or showing the signs of instability. What are the signs of instability? Hasya signs. Hasya signs. H stands for what, guys? H stands for hypotension. Okay. A stands for altered mental status. Altered mental status. S stands for if the patient is having signs of shock. I stands for ischemic chest discomfort, and A stands for acute heart failure. Okay, so Hasya signs, very, very important, guys. If the patient is having Hasya sign, H-A-S-I-A, that is the signs of instability. What is the next best management for Hasya, for unstable tachycardia? It is always cardioversion, yani कि you are giving shock to the patient. But don't tell, sir, I will be giving a asynchronous. Asynchronous is given only in cardiac arrest. You have to go for synchronized cardioversion over here. Synchronized cardioversion in unstable tachycardia. Okay. Now, after unstable, we'll go for stable tachycardia. Stable tachycardia means the patient is not having any signs of instability. Now, what you will do? In this patient, we have to go for VABC. V stands for what? Vagal maneuver. A stands for what? Adenosine. When you are giving adenosine to this patient, first, initially, we are giving what? 6 milligram of adenosine, and we'll see how the patient is reacting. The patient is still not improving with 6, then we increase the dose to 12. So that's regarding what? Adenosine. Apart from that, B is what? Beta blocker. In the beta blocker, we are giving what? Injection of sotalol, most commonly, guys, 100 milligram over 10 minutes. Okay? C is calcium channel blocker, can also be given. That is regarding the management of stable tachycardia. Okay. Monitoring in anesthesia. So during anesthesia, what are the things that you monitor for? You monitor the patient's oxygenation. The patient's oxygenation can be monitored by pulse oximetry, which usually works on a principle of Beer-Lambert's law. Beer-Lambert's law. Next, you monitor the patient's ventilation. For monitoring the patient ventilation, you go for capnography. We have already discussed. Next, you monitor the patient's circulation. Circulation monitoring can be done by ECG, BP, and transesophageal echocardiography. But again, transesophageal echocardiography is used for major surgeries or to detect venous air embolism, okay? But most commonly ECG and BP. ECG, you have to remember, two leads are very important. 12 lead ECG is there, only two leads are important, lead 2 and lead 5. Lead 2 of the ECG will detect arrhythmias, whereas with lead 5 you can detect ischemias. Okay, under BP again you are having what? BP, you are having NIBP and IBP. NIBP is non-invasive BP monitoring and IBP is invasive BP monitoring. Okay, this is transesophageal echocardiography, which is usually used for venous air embolism. Okay, next, temperature monitoring. Again, in temperature you are having what? Peripheral and core temperature, but commonly we use core temperature. Commonly means for normal small surgeries we are using peripheral temperature, but for major surgeries we use core temperature monitoring. And what are the sites of core temperature monitoring? The most common site is esophagus. Esophagus. Whereas the most accurate site for core temperature monitoring is, it's an invasive site, which is pulmonary artery. Pulmonary artery. Next is awareness. Guys, remember, awareness during anesthesia can be monitored by a monitor called as BIS. BIS is nothing but bispectral index. It calculates the sum of EEGs and gives a value. So after getting a value of BIS, sometimes you can get a value of 100. Value of 100, BIS value of 100, 65 to 85, 40 to 65 and less than 40. Remember, BIS value of 100 means patient is fully awake. 65 to 85 means patient is sedative. It is a sedative BIS. Okay. 40 to 65 means this is the surgical BIS. Yani ke for any surgeries, this is the BIS value required. This kind of awareness is required. Patient will be sedated, but patient will be deeply sedated. Okay. Less than 40 means it's a deep hypnotic state. Deep hypnotic state. Okay, this is regarding what? BIS value, bispectral index. Next is what, guys? Next is the neuromuscular monitoring. In the neuromuscular monitoring, what is the most common nerve that is? Remember, in neuromuscular monitoring we are having many monitors. Train of 4 is there, single twitch is there. There are many monitors. Most commonly used is train of 4. And what is the most common nerve that is being used, guys? It is the ulnar nerve, and the muscle involved is adductor pollicis. Adductor pollicis. Very, very important. Okay, now what basically we do is we connect this monitor and we give 4 twitches and we see the twitch response. After we give 4 stimulus and we see the twitch response. So look over here, guys. Imagine this is like I have not received any muscle relaxant, and train of 4, like basically here some electrodes are placed over here. Okay, and now 4 twitches are given, 4 stimulus are given. Just look over here. On 4 stimulus, what will happen to my thumb? First stimulus like this, second stimulus like this, third stimulus, fourth stimulus. Yani ki all 4 twitches are visible in patients who doesn't receive any muscle relaxant. With muscle relaxant, there are 2 kinds of muscle relaxant: depolarizing and non-depolarizing. With depolarizing muscle relaxant, what you will see? Imagine I have been given depolarizing muscle relaxant like scoline. Now after giving scoline, now you will stimulate the adductor pollicis muscle and you see the twitch. First twitch like this, second twitch same like this, third twitch same like this, fourth twitch same like this. So basically all 4 twitches are coming, but without muscle relaxant, twitch was like this.